All right. So let's start. Um, as I said, we are doing pharmacology on maternity. Okay. And, and so the first group of medications we are going to talk about are tocolytics, right? Are tocolytics. So tocolytics, we'll take one of them, which is magnesium sulfate, which forms part of tocolytics, right? And then we will talk much on them. For the other ones like nifedipine, I think the last time I made mention of nifedipine, right? And then other examples like indomethacin, terbutaline, which are all examples of tocolytics that are used in halting the progress of what you call labor, right? And so what you need to understand is that tocolytics are medications. Okay, they are a group of medications that are used in what you call halting of labor, or to what it does that it relaxes the uterus, okay, and then suppresses urethral activity. I hope you get me. So tocolytics are medication that produces urethral relaxation and suppress what you call urethral activity. It halts contractions and prevents preterm birth. So when we're doing preterm labor, I spoke about tocolytics that if someone is experiencing what they call preterm labor, and the healthcare provider, based on assessment, probably if the fetus is born, it's the fetus will have some form of complications, and then the healthcare provider then decides to kind of halt the labor that is ongoing with these medications, right? And so they cause urethral relaxation and suppress what you call urethral activity. Each of them will have what you call their effects that it will have on the system. So if you take something like the calcium channel blockers, example being nifedipine, right? What nifedipine would do is that nifedipine is a calcium channel blocker. What it does is that it blocks what you call calcium entry into the urethral muscles and then stops what you call contractions. That is what the Philippine does. It is even though it is a calcium channel blocker, we know it is used in managing hypertension and then other cardio condition. It also useful, okay, in halting what you call labor progress in preterm labor. Okay. Then you can also talk about NSAID like indomethacin, right? And the indomethacin is also a medication that reduces prostaglandin production. Prostaglandin helps to stimulate what you call urethral contractions, right? So when you suppress it, you are going to stop what you call contraction from progressing. And then we have terbutaline, right, which is also relaxes smooth muscles, so typically those that are within the uterus, and then it also helps to relax the uterus, stops uterine contractions and all that. So these are some of the examples of what do you call tocolytics. I will speak on max sulfate. That's why I haven't spoken about that. We can also use max sulfate, which will also kind of use to protect the brain, right? It also kind of helps to protect the brain, reduces the frequency and then intensity of contractions. They all helps to suppress what you call uterine contraction to prevent the progress of labor. If it is noted that there's going to be preterm labor. So when it comes to your tocolytics, I've made mention of about four. Um, Terbutaline, I've made mention of indomethacin, I've made mention of max sulfate, and then nifedipine, which is a calcium channel blocker. We all need to know, right? When you are giving tocolytics, what are some of the things you need to know regarding tocolytic administration? You position the client on the side to enhance placental perfusion and then reduces pressure on the cervix. You have to monitor client vitals, right? fetal status and then labor status frequently, according to agency or hospital protocol. You need to monitor for adverse effects of the medication. So when you are giving something like the nifedipine, since we know that the nifedipine is a calcium channel blocker, which also affects your heart rate, affects your blood pressure and all that. When you're giving it in this instant, you should be able to know that you have to monitor for adverse effects of it, which can cause, hypotension and can also cause bradycardia as well. And so you need to understand and then monitor what you call the side effects of them or adverse. You monitor daily weights. So monitor daily weights and then input and output, especially if you are giving max sulfate, right? Max sulfate affects what they call kidney perfusion. And so when you are giving max sulfate, one of the things that will help you to know that clients is experiencing max sulfate toxicity is monitoring the urine output. And so if someone is experiencing max sulfate toxicity, urine output typically reduces. Okay, so you have to monitor input and output so that you can monitor what you call the kidney as well. Then you offer comfort measures, social support, and all that for family. Okay, so these are general intervention that you have to initiate if a client is taking what you call tocolytics, right? So this is for general intervention for tocolytics. As I said, I'm going to take one of them, which is max sulfate. They typically like asking a lot of questions on. And so magnesium sulfate. You can't do maternity and then without knowing much about max sulfate. We are not going to go into the protocols, how you're going to administer. But I've not even seen an NCLEX asking about how you should be giving it. At least we need to know that it is a high alert medication. And so if you are to give your max sulfate, you should give it using what you call an IV pump, okay, so that you can regulate it and all that. But how our midwives will give it every hour, every those kind of things are not of much interest to us. Okay, so we'll look at what we monitor if someone is on max sulfate. What would be the things that you need to inform healthcare provider about it when one is taking max sulfate? So max sulfate, as I said, it is a central nervous system depressant and then also anti-seizure medication. Okay. And anti-seizure medication, it suppresses our muscles. Okay, that is why it is used in what we call eclampsia or preeclampsia. So if someone is experiencing eclampsia, we say that eclampsia is the seizure that occurs that is linked to elevated blood pressure. Okay, so if the person is fitting because of the effects of what you call max sulfate on our central nervous system by suppressing our muscles, it helps to control what you call the seizure the person is experiencing. Okay, so if you are then giving back sulfate, one of the things that you need to monitor for is our muscle reflexes. Okay, so the medication causes smooth muscle relaxation, stopping preterm labor to prevent what you call preterm birth, although it is less commonly used for this effect in practice. Okay, preventing and controlling seizure in preeclampsia and eclamptic clients. So I've said that people experiencing preeclampsia and eclampsia, we know that seizure occurs when there is eclampsia as a result of elevated blood pressure. And so this medication will help kind of calm the muscles down. Okay. Adverse effects of what you call max sulfate. When you are giving max sulfate, what are the important things you monitor? So magnesium sulfate causes respiratory depression. Very, very, very important. So when you are giving max sulfate, one of the key things you have to monitor is the respiratory rate. Okay, you have to monitor the respiratory status, the respiratory rate, depressed reflexes. You have to monitor for depressed reflexes because we said that the smooth muscles will get the medication suppresses smooth muscles. Okay, and so our reflexes are going to be depressed. flashing, hypotension, extreme muscle weakness, decreased urine output. There could be some form of pulmonary edema, and then elevated magnesium level, right? So you need to monitor serum magnesium level. Okay, you need to monitor serum magnesium level. And then continuous intravenous infusion increases the risk of magnesium toxicity in the newborn as well. So there could be magnesium toxicity also occurring in the newborn if the mother receives or receive a lot of what you call the medication. Okay, so we should understand that respiratory depression depressed reflexes. So I will talk much of the reflexes and how you understand how to grade what you call the reflexes. High dose can cause loss of deep tendon reflexes. It can cause some form of heart blocks, respiratory paralysis, and then cardiac arrest as well. So when you are given this, please understand that one of the things you are going to pay much attention to is the respiratory status or respiratory assessment. The medication is contraindicated in people with what you call heart block, myocardial damages, and then kidney failure, because we said that this medication can also affect kidney perfusion, right? And so if someone is having kidney failure, it is not ideal to administer max sulfates to that individual. The medication also, so even if you are going to use it in people with kidney related issue, you have to be very careful with it. The best is to avoid it to use it. But if there is no other option and you have to use it, you have to be very careful with its usage. Let's look at what you monitor when giving max sulfate. So when you are giving max sulfate, you have to assess the clients, the mother, and the fetal assessment needs to be done so that you know their baseline, baseline fetal heart rate, client vitals, okay, and then the baseline before you start your therapy. What was the blood pressure? What was the respiratory rate and all that you need to monitor? You need to monitor contraction, how contractions were even occurring, the consistency at which it was occurring before you start your medication administration. You monitor vitals, especially respiratory rate, every 30 to 60 minutes. You have to assess renal function and then electrocardiogram for cardiac function, because we said that this medication can also cause heart block. So if someone is going on max sulfate, you need to know how the heart is performing even before the medication will be started. Okay. Max sulfates, magnesium levels every 6 hours, or if signs of toxicity are noted. The target range when used as a tocolytic is 4 to 7. Okay, so when you are giving your max sulfate, your target range, because you are giving what you call magnesium, we know that the magnesium level is going to increase. So we call something therapeutic range, right? I know that the normal magnesium, what is the normal magnesium level? Okay, normal serum magnesium level, I think is 2.5 to is it 4, so you can confirm for me, okay? But the moment you give someone magnesium, you don't expect the person to retain the normal serum magnesium level. Then there is something we call therapeutic range. The magnesium level will definitely go up. But what is the target range that you don't want the client to cross? So this is the target range if someone is taking what they call magnesium. So you want to maintain the magnesium level between 4 to 7.5. If it exceeds this, it means that the individual is experiencing magnesium toxicity. Okay. If the level increases, you might need to stop the medication, inform the healthcare provider. Okay. Another thing you have to also understand is that when administering magnesium, always administer magnesium by an IV infusion via an infusion pump so that you can monitor the rate at which you are administering your medication. Okay, so carefully monitor the dose being administered and follow agency protocol for administration. So what I want you to understand is that we don't give it, by what you call like a push. you have to give it via an infusion pump so that you can regulate the amount you are giving because of its side effects where it can affect the respiratory rates, cause cardiac arrest and all that. Okay. Keep calcium gluconate. This is also very important. What you need to have at hand if someone is experiencing toxicity level is calcium gluconate. So calcium gluconate is the antidote for what you call magnesium toxicity. So when someone is taking magnesium or magnesium sulfate and the person is experiencing toxic effect or toxicity of the medication, what we give is what? Calcium gluconate. So keep calcium gluconate along with what you call syringe and needle readily accessible in case of what you call magnesium overdose or magnesium sulfate overdose because calcium gluconate antagonizes the effect of what you call the magnesium, right? And then you have your resuscitation equipment at the bedside, oxygen, suction machine, and all that. In case the client goes into cardiac arrest or there is the need for you to administer oxygen, respiratory rate is down and all that, you would have to give probably resuscitate the client, give oxygen suction when there's a need for you to suction. Then you monitor for deep tendon reflexes every hour for signs of developing toxicity. So we said that magnesium sulfate, that's what it suppresses our smooth muscles. And so if someone is experiencing seizure, we can give max of it, especially if it is eclampsia or preeclampsia, right? And what it would do is that it will help to suppress the muscles that are erratic or that are activated, right? And so our muscles, okay, our reflexes are graded between 0 to 4, okay, for the purpose of our studies, okay, our reflexes are graded from 0 to 4. I do reflex is 2. So whenever I'm teaching, I use this that, for instance, as I am here, as you are there, you don't have any issue with your reflexes. You have normal reflexes. So if we are to grade your reflexes should be graded as 2, which is the normal reflex. However, if someone is experiencing seizure, it means that the person goes this direction. The reflexes increases when one is experiencing seizure. So it is either the person will be having 3 or 4 in terms of reflexes grading. Okay. So if someone is experiencing seizures, the person is aggressive in terms of the movement, as we all know, when someone is experiencing seizures. And so with that, we grade either 3 or 4, depending on how intense the reflexes. I hope you are getting me. And so if you are giving max of it, we expect that the reflex will drop from 4 or 3 to the normal, which is 2. Okay. So when you are giving magnesium sulfate, we want to see the reflex dropping to 2, either from 4 or 3 to 2. Okay. Now, when you are giving the medication or when you are giving magnesium sulfate, and after you have administered it, you assess the client and you realize that the client's reflexes are still high, either 3 or 4. What it means is that you would have to increase the dose of the medication, or you would have to increase the amount of the magnesium sulfate you are giving because the reflexes are still high. Okay. However, if you are giving it and the reflexes you assess and the person it has attained normal body movement or normal reflex, you either maintain what you call the amount you are giving, or based on healthcare providers, what you call assessment, whether you maintain or if the goal had been achieved, you have to maintain or you stop. Okay. But then if the client is taking max sulfate and you do the reflexes and you realize that the person is not moving anymore, there's what you call suppressed deep tendon reflexes. Suppressed deep tendon reflexes means that the movement is not normal. It has dropped as is expected. Okay. And so it is either the person is having 1 or 0. 0 means that there is no reflexes at all. And then 1 means that there is what we call decreased reflex. And so when you have a decreased reflex, what it means is that you either have to taper the dose down or you have to stop the medication based on what they call the healthcare provider's instruction. So what I want you to understand is that when you are giving magnesium sulfate, you have to monitor for deep tendon reflexes. If the deep tendon reflexes are still high, either 3 or 4, based on your assessment, you would either need to maintain the dose or increase the amount of the magnesium you are giving. If you are giving your magnesium sulfate and you realize that the client's reflexes are down, either 1 or 0. As I said, 0 means that there's no movement. Even there's no movement, client cannot even move what you call the hands and all that. The reflexes are not there. In that instant, you would have to stop what you call the medication and even go ahead to give your calcium gluconate. Okay. But if the reflex is 1, you will also stop it. I hope you are getting me. So the idea I want you to understand is where you would have to increase the amount of magnesium and where you might have to stop the magnesium when you are administering it. And so definitely if someone is having decreased reflexes, the respiratory rate is going to also be affected. There's going to be respiratory depression and all that, where you might need to stop what you call your medication. Any question on what I said? Let me see, seems someone has kept a question. Okay, normal magnesium level is 0.7 to 1.5. Okay. Or okay, so we are using this, right? Let's use the 1.7 to 2.6. That, when it comes to lab values, every material and what is, but for the purpose of the NCLEX, they will definitely give you the reference range, especially for our case study purposes. Okay, so 1.7 to 2.6. Okay, the normal max magnesium level. Okay, serum magnesium level. Thank you. And so if the person is taking magnesium sulfate, you expect that the client will maintain this. This should be the therapeutic for someone who is taking what you call the magnesium sulfate. Right. Any question on what I said? Any question on anything I made mention of? If you want anything, any clarification, any inputs, you want to add up to whatever I said, you can come up with it as well. Then you monitor intake and output. I've said that magnesium will have an effect on your kidney. So you monitor urine output every hourly. Okay. So output should be maintained at least 25 to 30 ml per hour because the medication is eliminated through the kidneys and all that. So there's possibility of kidney failure, right? So you have to maintain adequate kidney perfusion. Then you closely monitor client receiving magnesium sulfate for magnesium sulfate toxicity. You call the healthcare provider. If respiratory rates are 12 beats per minute or 12 breaths per minute or less, indicating that there's respiratory depression or if any. So this is one thing that you would have to call the healthcare provider immediately. So if you are giving max sulfates, these are the things that has to guide you. So when respiratory level drops to 12 or below, you would have to call the healthcare provider. If urine output is less than 25 to 30 ml per hour, it's a red flag. You have to inform the healthcare provider. Medication will likely be stopped or the dose will be decreased. Okay. And then all the other things I made mention of. These are the things that when you are administering magnesium sulfate to a client, you would have to monitor. Any question, any addition, any inputs?
Okay.
Yeah, hello.
Please, can you clarify this for me again?
Can you raise up your voice? I can't hear you.
Yes.
Bluetooth is. So I was saying that can you clarify this point for me? Did you say that if the magnesium sulfate is high, you either maintain the dose or reduce the dose? Did you say something like that?
No.
Please, can you clarify it for me?
I said that. No, can you ask your question again? I'm confused. Can you ask your question again? Ada Presla, can you come again with your question?
Hello.
Yes, can you ask your question again?
So my question is, did you say if like in case you notice that the magnesium sulfate is high, like the intervention that you have to, the intervention that you have to go by, do you have to reduce the dose of the magnesium sulfate, or you maintain the dose of the magnesium sulfate?
Well, if magnesium toxicity occurred, you wouldn't maintain the amount, you wouldn't also increase. You would definitely either have to taper it down or you stop.
Okay.
Okay, so there's no way if magnesium level is high, you are going to maintain and then you are going to increase. You either have to stop or you taper it down.
Okay. All right.
Yes.
Thank you. So the same as if it is low.
So if it is low, we increase. Definitely you're going to increase. Okay.
Okay.
Uh-huh.
All right. Thank you.
All right. Any other question? All right. Any other? Okay, so we can progress. Okay. So let's talk about our steroids that are used in what you call newborn, right? I know we know this, that when during preterm labor, we would have to give our steroids to the mother. The one thing the NCLEX sometimes asks is who you are going to give it to. They want to know who, they know that yes, you use the steroids, but who received the steroids? Is it the mother or the fetus or the baby? That is what we need to know. Okay. And so steroids are used in what you call during labor if it is noted that the mother is going to have a preterm labor, and then we know that the lung might have not been fully matured. Okay, and so we use the steroids during that time. We give the steroids to the mother, and then it helps with fetal lung maturity. I hope you get me. That is what you need to understand, that the medication is not given to the fetus. Of course, it is the mother who will receive it through the maternal blood. The fetus is going to benefit from it, and then it will help with the lung maturity. I hope you are getting me. So I saw one question that way where they twisted it as if it says that they administer the medication to the baby. But you need to understand that the medication is not to be given to the baby, but rather the mother who is going to receive what you call the medication, and then the baby will benefit from it. I hope you get me. So steroids are used when it is noted that it's going to be preterm labor. That is why along the line, the healthcare provider would have to give the tocolytics to kind of halt the what you call the progress of the labor, so they can give the other medication that needs to be given for the lung maturity and other things. Okay. So steroids examples are betamethasone and then dexamethasone. If you have done what you call endocrine, you should be good at what you call steroids and what steroid does to the body when someone is taking steroids. Okay, so these are corticosteroids that increases the production of what you call surfactant to accelerate fetal lung maturity and reduces incidence of what you call respiratory distress syndrome. Okay, to help with the lung maturity in what you call the fetus, but it is given to the mother. That is what I want you to understand. For a client in preterm labor between 28 to 32 weeks gestation, whose labor can be inhibited for at least 48 hours without jeopardizing what they call the pregnancy or the fetus. So if the healthcare provider can kind of halt the pregnancy for about 48 hours, and then there wouldn't be any issue with the mother or the fetus, then we can do that and give what they call our steroids so that it will help with what they call the production of surfactants to help with the land being mature. Okay. When we are giving steroids, like I said, if you have done what you call endocrine, you'll be able to know much about Addison and Cushing's, where we speak largely on what you call steroids. And so steroids will have an effect on what you call one's ability to resist infection. So there's decreased resistance to infection. So you have to monitor for signs of infection if the individual is taking steroids. Pulmonary edema, as we know that steroids causes sodium retention. Okay, sodium and fluid retention. So there's going to be fluid retention, which can cause pulmonary edema, and then it also elevates the glucose level. So you have to monitor what you call the glucose level. I hope you are getting me. And then, especially when you are giving it in people who are diabetic, right? And so elevated blood glucose level can occur in clients with what you call DM. When you are giving it, you monitor for signs of vital signs and lung assessment for the edema. Infection, you have to monitor for signs of infection. Then WBC counts can go up because of the infection and all that if infection sets in. Glucose level, you need to monitor, and then you have to administer tests by an iron. So as I said, we give it to the mother, administer by deep intramuscular injection to what you call the mother. When you are giving steroids, at least these are the basics you need to understand when it comes to steroids. The take home is that the medication is given to the mother. It helps with lung maturity. So when you are reading your question, someone is in labor, and then you look at the week of gestation. That is why we did signs of true labor. I told you that at that time. When you look at it, a person is around 30 weeks of gestation, 32 weeks, and they are asking you what will be the intervention. And then you know that the person is going into preterm labor. For preterm labor, you might have to give your steroids, right, to help with the lung maturity. Then we come to medication that can also stimulate contraction. We have spoken on medication that will suppress contraction. When it comes to the aspect of the lung maturity, I will talk about surfactant, right? The lung surfactant itself, which we can give to the baby. Okay, it's in my next slide. But for now, we are talking about what we give to the mother. So we are now coming to what you can give to enhance contraction. I told you that during labor, contractions are needed to enhance, or you need oxytocin to enhance contractions for dilation and all that. Even after delivery, you need the uterus to contract so that it will press on the vessels to stop what you call bleeding and all that. And so we have uterine stimulant. And then an example of a uterine stimulant is oxytocin. We can't also talk about a medication when it comes to meds without talking about oxytocin. So oxytocin stimulates the smooth muscles of the uterus and then increases the force, the frequency, and the duration of what you call contraction. So if someone is in labor and then the labor is not progressing as expected and you want to augment labor, what we use for labor augmenting or to augment labor is our oxytocin. Some books, they might not use oxytocin, but they might use pitocin. So whether oxytocin or pitocin, you know that they are all what you call uterine stimulants. So if you don't see oxytocin and you see pitocin somewhere, it is the same medication they are talking about. Okay. Oxytocin also promotes milk letdown. And so when the mother is breastfeeding and all that, the purpose of oxytocin is also to help with the milk coming and all that. I hope that one we know. for induction of labor, oxytocin is administered by IV route. Okay, so other routes you can give is IM. If you are injecting it IM, you have to aspiration is necessary to avoid what you call injection into the blood vessels. This is the fundamentals. When you are doing fundamentals, you learn about how to medication administration. Okay, which is there. When you are giving oxytocin, what you have to have at hand is magnesium sulfate. Okay. Remember that the oxytocin is to enhance contraction. So when you have given oxytocin and then there is what you call hyperstimulation of the uterus and you want to calm it down, you need what you call your tocolytic, that is mag sulfate. So magnesium sulfate should be readily accessible in case relaxation of the myometrium is necessary. Minimal cervical change usually is noted until the client goes into what they call active phase of labor. Induce or augment labor, as I said, it is used for induction or to augment labor to control postpartum hemorrhage, PPH, right? I told you that if someone is having uterine atony, we spoke about atony last week, where the uterus is not contracting adequately, right? What we do is that we can give our oxytocin to enhance the uterine contraction and to prevent what they call uterine atony, and then to control postpartum hemorrhage, and then manages what you call incomplete abortion and all that. When you are giving this, what are the expected side effects? Some people are allergic to it. So adverse effects include allergies, dysrhythmias. It can affect what you call your heart rate and all that. Changes in blood pressure can also occur, and then uterine rupture. If there is hyper stimulation of the uterus, it can cause the uterus to rupture, and then water intoxication. So you need to monitor. It could cause accumulation of fluid in the system where it could lead to water intoxication. Oxytocin may produce uterine hypertonicity, resulting in fetal or client adversive. So you need to monitor the the fetal status too. You need to monitor fetal assessment, okay, to see whether fetal heart rate is affected when one is taking oxytocin. Postpartum hemorrhage can occur and should be monitored for because the uterus may become atonic when the medication wears off, right? So if you are giving magnesium sulfate for the purpose of uterine contraction, especially postpartum, and the medication wears off and the uterus is not contracting again, the client can experience what they call postpartum hemorrhage. So you have to continue to monitor for signs of PPH, right? And then oxytocin should not be used in a client who cannot also deliver vaginally or in a client with hyperuterine contraction. It is also contraindicated in what you call active fetal or active genital herpes. When we're doing touch infection, if you were with me from the beginning, during touch, infections that should be avoided when one is pregnant. One of them I made mention is what? Herpes, right? Herpes. And I made mention that in active herpes infection, we don't even allow the client to undergo spontaneous vaginal delivery because of because the fetus could be affected during labor or during delivery. And so when the person is in labor, we don't even have to augment. We don't even have to give something to augment that will cause the baby to come out. But when you do that and the baby is coming out, the fetus can contract the infection from there. Okay, that is why probably it's not appropriate to give oxytocin to the mother when the mother is having active herpes infection. Straightforward, there's going to be what you call CS to be done to take the baby off. Okay, in such instant. Okay, that is that. So when you are giving it, you monitor the client vital signs. every 15 minutes, especially the blood pressure and the heart rate. You weigh the client's intake and output, very necessary, level of consciousness, lung assessment. You need to monitor all that when one is taking oxytocin. You need to monitor the frequency, the duration, and then the force of contraction. That is the purpose of the medication. So if you are giving it, monitor to see whether the medication is in excess, hyperuterine contraction. You need to monitor for that. Then you do your fetal heart rate assessment every 15 minutes. You notify the healthcare provider if there is a significant change in what you call the fetal heart rate. Okay. It could either be fetal tachycardia or fetal bradycardia, any of them. That is why it says that if there is a significant change. So when you are giving it, you monitor for either fetal tachycardia or fetal bradycardia. I hope you get it. So you need to monitor for any of them. If you notice that there is what you call a significant change in the fetal heart rate, we've done the various fetal heart rate monitoring and all that. So I believe for those who were with me from the beginning, you understand it. But if you just joined, I understand. As I said, it's going through some way. We even have the recordings, everything then. And then we'll still go over this again sometime. Okay. And so the recordings are there. You have access to the class recording. You can visit them anytime you want to visit them. Okay. Then the medication should be given via an IV pump so that you can monitor the rate at which you are giving the medication. Then you have to carefully monitor the dose being administered. Do not leave the client unattended to while the client is taking the medication. You must have your oxygen at the bedside if you need to resuscitate the client or you need to give oxygen. Monitor for what you call hypertonic contractions, okay, and non-reassuring fetal heart rates. That is why I'm not talking about whether deceleration or whatever. It says that non-reassuring. We know the non-reassuring fetal heart rates, right? So if you are monitoring the fetus and you notice that there is a non-reassuring fetal heart rate when the client is on oxytocin, you would have to notify the healthcare provider. You stop medication if there is what they call uterine hyperstimulation or a non-reassuring fetal heart rate. Okay. You have to stop the medication, turn the client to the side, increase what you call the dose of your medication, and then you administer oxygen. You remember what you call when we're doing the non-reassuring fetal heart rate, and then I gave you a general principle to help you remember your intervention. Okay, I said that you turn the client to the side, you have to administer your IV fluids, you administer oxygen, you inform the healthcare provider about it. Okay. Then you monitor for signs of water intoxication. You have your resuscitation equipment at the bedside so that if you need to intervene, you will intervene appropriately. That is on what you call oxytocin administration. Any question on oxytocin administration? Any inputs on oxytocin? If you have a question on oxytocin administration, you can ask, you can bring it up before we go or we continue with our metagonavine. Okay, so if you remember this, when we're talking about PPH, okay, I made mention of this medication that we give it to stop what they call postpartum hemorrhage. Okay, so metagonavine is given in PPH when someone is experiencing postpartum hemorrhage. Okay, and then you want to stimulate contractions. Okay, to help press on the vessels to cause vasoconstriction to stop the bleeding. That is the purpose of this. So it directly stimulates uterine muscles, increase the force and frequency of contraction, and produces what you call a firm contraction of the uterus. It can produce atrial vasoconstriction and then vasospasm of the coronary arteries. So, like I said, that is the purpose. It actually constricts the vessels. And when the vessels get constricted, hemorrhage or bleeding will stop. Okay. It is used for managing postpartum hemorrhage. Or post-abortal hemorrhage resulting from atony or involution. Okay. All right. So if the uterus is not contracting adequately, you can also give this to help the uterus to contract in postpartum, not during labor. So during postpartum, when the person is bleeding, okay, and the cause of it is as a result of uterine atony, you can give it to also stimulate contractions. The medication side effects are it causes nausea, uterine cramping, bradycardia, dysrhythmia, a myocardial infection, and then severe hypertension. So this medication is contraindicated in people with cardiovascular history of cardiovascular condition like hypertension. So high dose are associated with peripheral vasospasm or vasoconstriction, angina can occur, confusion, respiratory depression, and all that could happen. Contraindicated during pregnancy. Of course, you cannot give this during pregnancy. As I said, it is given in the postpartum period. So that is what we need to understand. Even though it causes uterine contraction, but you cannot give it during pregnancy or you cannot give it during labor. It should be given in the postpartum when the individual is experiencing hemorrhage or hemorrhaging. And then in clients with significant cardiovascular disease, peripheral artery disease or hypertension. Okay, the condition causes what you call constriction. So if you are already hypertensive and you go take this medication and it causes your vessels to occlude, heart rate is going to go up or blood pressure is going to go up and all that. So if the person is a known hypertensive, we don't use methylgonavine in managing what they call their PPH. Your monitoring, your intervention should be that you monitor vital signs, you monitor intake and output and all that. Level of consciousness, lung assessment should be done. You monitor for blood pressure closely. The medication, as I said, will cause vasoconstriction, which can elevate the blood pressure. So when you are giving this medication, you monitor for the blood pressure should be monitored closely, and then you withhold the medication and notify the healthcare provider if you note that the blood pressure had increased or there is what they call hypertension during administration. Monitor for uterine contraction, okay, because that is the purpose of the medication. You assess for chest pain, headache, shortness of breath, any abnormal findings whilst administering the medication, itching, pill, cold hands or feet. Okay, it could be that there is what you call decreased blood supply to the extremities. You assess the extremities for color, warmth, and movement and pain. You assess for vaginal bleeding. The purpose is to stop the bleeding. So whilst you are giving it, you have to continue to monitor for any form of what they call bleeding. Notify the healthcare provider if chest pain or other adverse effect that made mention of occurs. You can administer analgesics as prescribed. They may be required because the medication could also cause some form of painful uterine contraction. The take home is that check the blood pressure before administering gonavine. Okay, check the blood pressure before you administer this medication. This medication can produce severe hypertension and should be contraindicated during what they call pregnancy or when the person is already a known hypertensive. We shouldn't use this medication. That is on what they call methylgonavine. Any addition, any inputs, any clarification? All right, we can make progress. Okay, very soon we are getting there. Then our next one is lung surfactant. So I made mention of the steroids and how it is used during pregnancy, especially when there is preterm labor. Okay. We also use what they call the lung surfactant. And so the lung surfactants are rather given to the fetus. Okay. So when the baby is now born, okay, let's say there was preterm labor, the fetus is administered, is the baby is delivered, and then the lung is not fully matured. We give our surfactants. And so the surfactants replenish, or it's replenish, surfactant, and then restore surface activity to the lungs to prevent and treat respiratory distress syndrome. This one is given to the baby. This one is given directly to the baby by intratracheal routes. Okay, so I said that the steroids are given to the mother. The steroids will help with the production of the lung surfactant, but lung surfactants can also be given to what you call the fetus or the baby after the baby is born. Okay, you give this one directly to the baby. It helps to prevent or treat respiratory distress syndrome in premature newborns. Adverse effects will include some form of bradycardia and then oxygen desaturation. Pulmonary hemorrhage can occur, and then mucus plugging in the tracheal tube, what you call reflux, can occur during what you call administration. So you have to be careful. So surfactants are administered with caution in newborn because there's what you call risks of respiratory overload. The main thing I want you to take home from this is that we give the surfactant also to the newborn or premature newborn. We don't give it during labor. We give it after the newborn or after the baby is born. That is what I want you to understand from here. Any question on that? Any inputs? There's not so much to talk about on that. Okay. Then we talk about epidural block or epidural anesthesia. Now we are coming to the pain medication, when you can give your pain meds during labor, or which pain meds can you administer, and at what time can you give your pain meds. So when it comes to epidural block or epidural anesthesia, we know that we give it during labor, okay, to manage pain. Recently, it's one of them. The pain management that most anesthetists used, okay, in managing what you call labor pain. Okay, it's very effective, but it also has its downside or its side effects that can occur when you give it. So when you are giving epidural anesthesia for the clients in labor, what you need to understand is that one main side effect of it is that it produces hypotension, or it can cause hypotension. That is one of I think some of the questions I met was its effects and the intervention you take when the person is experiencing the hypotension. So what we have to understand is that when one is in labor, the person can take epidural anesthesia or epidural block, which is a regional anesthesia to control pain. However, it also inhibits what we call sympathetic nervous system. And so when you inhibit the sympathetic nervous system, you cause vasodilation. And so it is the vasodilation that produces the hypotension, or that causes the person to experience the hypotension. So when you are giving your epidural anesthesia to a laboring client, one thing you have to take note of is that you have to monitor for hypotension, because the epidural block or the epidural anesthesia causes vasodilation, and that could lead to hypotension or significant hypotension. So if a client exhibits hypotensive symptoms, some of the things they will experience that after they take their epidural anesthesia, they will tell you they are experiencing lightheadedness, nausea, some of them will complain of dizziness. The moment you are reading your question, you note that, kindly know that it is hypotension that is occurring. Whilst receiving epidural anesthesia, the nurse should first assess blood pressure to confirm the presence of hypotension before intervening. So if you are reading your question and then it says that a client is taking or a client is in labor and then epidural anesthesia or epidural block had been given, client complain of dizziness, nausea, and they ask you what will be your first intervention, and you have assess vital signs or check blood pressure, elevate the um, what do you call the lower end of the bed, inform the healthcare provider and other. Understand that the first thing you need to do is to establish the cause of the person experiencing the dizziness and all that. So the first thing you would have to do will be to monitor or to check what you call the blood pressure to ascertain that it is actually hypotension that is happening before you even intervene. If hypotension is there, your initial interventions will be to administer IV fluids, okay, to increase blood volume and then position the client in the left lateral position to alleviate what you call pressure on the vena cava. If the person is also experiencing what you call nausea, you can give ondansetron, which is an antiemetic. Okay, so if client is experiencing nausea and vomiting after you give your medication, you can give what you call ondansetron or Zofran. If hypotension persists or there is fetal distress, you have to administer what you call your IV vasopressors, okay, like ephedrine, okay, or and then apply your oxygen. And so what this means is that when you give an epidural anesthesia to a client and the client is experiencing hypotension, the first thing you do after you have checked the blood pressure to know that it is hypotension that is causing the person to experience the nausea, vomiting, dizziness, and all that, you have to first administer IV fluids. Okay, and then you change position. If all this are not able to resolve what you call the hypotension, then you go more aggressive, and then the more aggressive be to give your IV vasopressors. We don't give the IV vasopressors before we give what you call the IV fluids. If you give the vasopressors and then there is no much fluid in the system, it is a cost 90 job. So what you do first is that you first give your IV fluids, and if that is not able to resolve the hypotension, then you now go in with what you call your vasopressors. I hope you get me. Then you come in with your oxygen administration if you need to administer oxygen as well. Okay. Any question on what you call epidural anesthesia usage in what you call a laboring client or a client who is in labor? Okay, let's talk about how we can give our opiates or our pain medications during labor. Pain medication usage during labor. Okay, as we are monitoring all right, so as we are monitoring or as we are monitoring client who is in labor, who is in pain and need pain medication, we cannot just give our pain medication just like that. We cannot just give pain medication just because client is in labor and the client needs pain medication. We have time we can give it. Okay. And so what we need to understand is that this medication or pain medication are downers, right? I'm just bringing in this. They cause respiratory depression and all that. They can also cross the placenta barrier and then affect the fetus. Okay, so when you give your opiates to the mother and they cross the placenta barrier and the fetus get affected, what do you think will happen? It will cause respiratory depression in the fetus. That is why you should be able to know when to give what you call your opiates to the laboring client or the client who is in labor. So if a client is in labor and a client is in pain and you need to give what you call your opiates, you have to give the opiates to the client when the client is in active labor. It is said that, or I mean, scientifically, or it is known that when you give the medication during active labor, the medication stays in what you call the maternal, what you call blood, and then its effects will fully be seen where it has reduced the pain and all that. However, if you give this medication to a client who is in the transition, we said that transition is what you call what the third phase, right? The third phase of the first stage, where the mother is just moving into stage 2, where the mother can, I mean, will go into labor or will deliver. I hope you get me. So we give our opiates to the mother when the mother is in the active phase. Okay, that is the best time to give your opiates. And then the opiates too also have a half-life of about 2 hours. Okay, about 2 to 4 hours. So you also have to understand that when you are giving your pain medication to the mother, the pain medication should be given when the mother is noted that the mother will deliver like 2 to 4 hours after you have given your pain medication. So if you give the medication to the mother and then the mother delivers in less than what you call, in less than, let's say, 1 hour, just after you gave the medication, in less than 1 hour, the mother delivered. What it means is that by that time, the medication is still in the system and could cross the placenta barrier and affect the baby. So we don't give the medication when we know that the mother is going to deliver in a short while. I hope you get me. So we give it when we know that the mother will go into labor or the mother will deliver in about 2 to 4 hours time, because that is a half-life. But then the medication might have weared off from the system. So let me go through what I have here. When I'm done, I will explain it better for you again. So our narcotics example, we have them meperidine, nalbuphine, and all that can be given during labor. Okay, during peak of what we call contractions. Okay, they are given during peak of contraction. That is why I said that we give it during active labor. That is when contraction had peaked and then contraction had well established. During the latent phase, contraction or labor hadn't really established itself. I hope you get me. So we give it to the mother when the contractions had peaked or at it peaked, which is during what we call active phase of what we call labor. So during the peak of contraction, this can help decrease sedation of what we call the fetus and then subsequent newborn respiratory depression. Intraplacental blood flow is significantly reduced during contraction peaks, and then administration of IV medication at this time will result in less medication crossing what you call the placenta barrier. So what it means is that during the time of what you call the peak of contraction, especially during active labor or during the stage of active labor, you have intraplacental blood flow significantly reduced. So what it means is that blood flow to what you call the fetus is slightly reduced during that time. And so when you give your medication, the medication will not likely, cross the placenta barrier and affect what you call the fetus. In addition, a higher concentration of the medication remains in the maternal vasculature, which increases the effectiveness of the pain medication. So we give it at the time when labor has been well established during active phase. Okay, that time the medication stays in the maternal blood and then its effects are fully seen. Okay. Narcotics do not typically inhibit contractions, okay, or labor progress when labor is well established, especially example when contractions are occurring every 2 to 5 minutes. So don't think that when you give your pain medication when contractions are well established, the pain medication will have an effect on contraction. No, it doesn't inhibit what they call contraction. So contraction can still occur. So what we have to understand is that the medication peak when you give your IV pain medication or your opiate to a laboring client, the medication peaks within 30 to 60 minutes. Okay, that is why I said that if you know that the mother is going to give birth in 1 hour time after you have given the or after you give the medication, don't give the medication at all, because when you give the medication will peak within 30 to 60 minutes. That is about 1 hour time. That is when the medication is high in the blood. And so by that time, if the mother goes into labor and is delivering, there's likelihood that the medication will cross the placenta barrier and the fetus will be affected, and you will have what you call respiratory depression, and then fetal sedation can all occur. So we make sure that the medication is given, okay, when you know that labor is likely going to occur in about 2 to 4 hours time. By then, like I said, the medication might have weared off from the system. So its duration of action, that is the opioid, is about 2 to 4 hours. If given near the time of birth, there's risks of what you call newborn respiratory depression and may require naloxone. I hope you all know that naloxone should be at hand when you are giving your opiates. Okay, that is the antidote for our opiate. So when you are giving the opiates, you must have your naloxone at hand. When there's respiratory depression or there's opiate toxicity, then you can give your naloxone. So when you are giving opiates to the laboring mother, understand that time is very, very important. Okay, time of administration of the medication is very important. Make sure that if you are going to give your medication, you are giving it at the time when contraction had peaked, mostly at what you call during the active phase, when contractions are very active, regular, and all that. And then you don't also give it when the mother, you know that the mother is likely going to go into labor in less than 1 hour after you have given the medication. You don't give it. Give it when you know that after giving, the mother is likely going to go into labor in about 4 hours time. By then, the opioid might have weared off from the system. So it is not likely going to cross the placenta barrier during labor. Okay. If IV opiates are safe for clients who will give birth 2 to 4 hours after administration, so that the side effects, so that the opioid effect has time to wear off before what you call birth. IV opiates are also best for clients in active labor. As I said, that is a time that you have what you call labor being well established, contraction had peaked, and so the medication stays in the blood, the maternal blood, and then doesn't get crossed what you call the placenta barrier. I hope you get me. Or those with a well-established contraction pattern, because opioid administration may slow labor progression in latent phase. Okay, so we usually give it when labor had been well established. Okay, that is with opiates administration, and when you give it, that is what I want you to know about opiates in labor. The best time to give it is when labor or contraction had peaked, especially at active labor. We give it. You don't give it when you know that the client is likely going to give birth in an hour time. You give it when you know that the client is likely going to deliver after 2 to 4 hours of administering the medication. If you give it and then in less than 1 hour, the client goes into labor, the medication will likely cross the placenta barrier, affect the fetus, and cause what you call respiratory depression and then fetal sedation. and then you might need to give your naloxone to reverse the effects of the opiates. That is on opiates administration. Any question on opiates usage during labor? Any question, any input, any clarification, any addition before I talk about the last thing are these medications that are contraindicated during pregnancy. ACE inhibitors, right? Lisinopril, whatever pril, cannot use it in labor or you cannot use it during pregnancy. Our ARBs, right? The ACE inhibitors and ARBs are like brothers, okay? And so, example of the ARBs, they are the Satans, okay? The Satan, whatever Satan. Then NSAIDs are also not quite used, okay, in what you call during pregnancy, not advisable. Then we have phenytoin, lithium, valproate, isotretinoin, methotrexate. If you remember I made mention of methotrexate usage, okay? What we're talking about ectopic pregnancy and then what do you call the other one I forgot. We talk about the usage of methotrexate. Remind me, and then warfarin. So you know that warfarin is contraindicated in pregnancy. Okay, when it comes to our anticoagulants, we can use heparin during pregnancy, but we cannot use warfarin during pregnancy. And then antibiotics in general are also not good to be used in pregnancy. Okay, unless there is extreme need for you to give what you call your antibiotics before you give them. Okay, molar pregnancy. Thank you. All right, so we made mention of methotrexate over there. Thank you, Stefan. So that brings us to an end on what I want to talk about regarding medication that we need to know when it comes to pregnancy or when it comes to maternity or when it comes to the NCLEX. And that is that for this part of our class. And so that brings us to an end on maternity. If you have a question, you have an input, you have a clarification you want to make, you can bring it up before we go into a few questions I put together. And then if we have time, we do something else. Any question, any inputs, any addition?
Flamingo.
Yeah, madam.
Yes, please. When you were talking about the preterm labor,
Mm,
yeah, you were saying something that the healthcare provider has to what was my question? Okay, I was waiting it. Hmm. Yeah, you were make like you were saying that the healthcare provider has to weigh is it the benefits. I forgot. Oh, you let me take it again. Let me check my notes because I wrote it somewhere. I'm coming.
okay, so if you can get us the question so that we will look at it together.
Please go to that slide and let me see.
You want me to go to preterm?
The medication for the preterm.
Okay. Is
Mm.
it which of them? Is it the surfactants from the so
Yes.
here.
not that one. The surfactant he said is given after the baby is born.
Uh-huh.
The
Steroids,
one they give
steroids,
for the
steroids,
yes, the
steroids.
steroids. Yes,
Mhm,
yes,
mhm.
yes. Yeah, for the monitoring for signs of infection, you were saying something that the healthcare provider has to weigh some. Like I got a question for you, but I don't know where I made. I
Hey,
can't find.
I wish you could quote me exactly what I said.
Yeah, I wrote it, but I can't find it.
Oh, really?
Can you
Um,
rephrase what you said from that side? Let me see.
okay, okay, over here, what I said was that surfactants are given, sorry, the steroids are given to the mother. Um, the healthcare provider would have to, um, before you give it, okay, the pregnancy would have to be delayed for about 48 hours because you need to give the medication,
Exactly that
to
side.
work,
Yes,
for the
exactly.
medication to work before the baby is delivered. Uh-huh, and all that.
So my question was that, what if the woman, like as you give the medication and it's not up to 48 hours, and
Uh-huh,
then you see where that we have the precipitous labor and other things,
uh-huh, uh-huh,
and since
uh-huh,
it's a preterm and
uh-huh,
then
uh-huh,
it's small, the baby
uh-huh,
is small,
mhm,
like the weight is small. You see, sometimes they just come pro like that.
mhm,
And maybe you've given the medication, but it's not up to 48 hours. So
mhm,
in that state, after
mhm.
that, what are you going to do? Are you
That
going
is
to give
that is
the
why
sulfate?
that yes, that is why the surfactants are there.
Okay, okay, okay,
That's why the surfactants are there.
okay.
So the surfactants basically do the same work the steroids will do. Okay. Uh-huh. But then what you need to understand is that one is given to the baby, one is given to the mother. So if we give our steroids to the mother, okay, if we give our steroids to the mother, and then let's say, I mean, the healthcare provider does everything possible, but still labor continues and then the baby is born, the lungs are not fully matured, of course we still need to take care of the baby. That's why we give what we call the surfactant. We give the surfactant to the baby now, and so to enhance with um, the lung maturity and to prevent the respiratory syndrome, distress syndrome.
Okay, thank you.
Yes. So someone too was asking, can you give can you give the narcotics? Okay, so is it please can the narcotics be given maybe 4 cm. I'm not getting back. If I get you right, which one you're asking whether it's advisable to give the narcotics around when you know that cervix is 4 cm dilated. 4 cm dilated, what is the in terms of what we learned regarding the stages of labor? What
It's an
phase is it?
active quiz.
Active phase. So you
Yeah,
can, and I said that is the best time to give. Okay.
okay.
That is the best time to give your opiates to the mother.
So, Amingo.
Yeah, madam.
So what if like you have a patient, the
Mm-hmm.
patient upon your assessment is
Mm-hmm.
maybe 2 cm or 3 cm. So
Mm-hmm.
it's in latent phase, right?
Yeah.
And then the contraction, that there is hyper contra contractions.
Mm-hmm. Mm-hmm.
Yeah, it's more than um like the contraction is severe, the patient is in pain and all that. Can you
Mm-hmm.
give the narcotic?
Even with that, you have to report it to the healthcare provider.
Okay, so with that you have to report to the
Yeah,
healthcare
because it's
provider.
not normal because of the hyperurethral activity.
Okay. And
I,
do they give
I,
muscle relaxant?
so
Apart
I
from
mean,
the tocolytics, do we give muscle relaxant?
muscle relaxant example, you're going to give
Oh,
like no, so do not, do not, do not do any of such thing. If the healthcare
okay.
provider hadn't instructed, I don't think they are going to give them as a relaxant. Okay, so So it is probably maybe the client, maybe they might have augmented. So the cause of the hyperactivity is what has to be established. Okay. It could be that the cause of it is probably maybe there was augmentation, client is on oxytocin, and the oxytocin is what is causing the hyperurethral activity. So you would then have to stop the oxytocin, and that would stop what you call the hyperurethral activity. Are you getting the point I'm making?
Because sorry, I think I made it because when I was in labor, always I want to reflect back. When I was in labor,
Mm.
when I went from the house, I had the pain. The contraction was like I couldn't stand. So when we
Mm.
went, they said it's
Mm.
2 cm. You see, 2 cm with all these contractions.
Mm.
So for the CTG, the tachograph machine, which was checking the contraction, they said yes,
Mm.
the contraction is high. So they
Mm.
won't give me a muscle relaxant. But that's what the RN said. But I didn't get
Okay.
the name of the medication.
But
Uh, and then pain meds as well. They gave me
Eh,
pain meds as
They
well.
give you pain medicine.
Yes, yes.
Yeah, so I don't want to say that they wouldn't give you the muscle, but I don't want us to go into that aspect. Okay.
That's why I'm
That
asking.
that that is
Is it good? Like
that is
is it
more
something
to
that
the
they're
head
supposed to
people.
give? Ah, okay,
The
okay.
muscle relaxant.
Yeah.
So I don't know whether they were giving it to relax the uterus because of the
Yes,
hyperurethral
because of the
activity.
hypertrophic activity.
Activity. Okay. Well, it could
So,
be useful, but that is if the healthcare provider has given the instruction. Probably there was an instruction for that to be given.
okay, okay.
That's why they went into
Because
that.
I was in latent phase and the contraction was too much. So they
Mm.
said they would give me a muscle relaxer to relax the muscles whilst labor. Like I go through the analysis. That's what they
Okay.
said. And they
Okay.
gave it to me.
Okay. Okay. All right.
I don't know. So,
Okay. Thank you. So we are learning, right? Any any other question? Any other inputs? Okay. So we can go through our questions. My midwives, if you are here, you talk, oh, you know this better than us. All right. Okay. Oh, because it's 10 clicks saying, all right, let's continue. So let's go through some few questions. The nurse is monitoring a client who is receiving what you call oxytocin to induce labor. Which assessment findings would cause the nurse to immediately discontinue the oxytocin infusion? Select all that apply. We have one, fatigue, drowsiness, uterine hyperstimulation, late deceleration of the fetal heart rate, and then five, early deceleration of the fetal heart rate. Mm-hmm. Three, some people are going for three, four. Mm-hmm. All right. All right. So you played safe game. I realized that people were playing very safe games and they won it, right? One of the things regarding satire is that if you are not sure, don't go for it, right? If you are not sure, if your mind is doing you like, it seems this is path, this is not path, don't go for it, okay? Go for what you are sure of. It's better to get partial score than to get some and at the end of the day, get some wrong and get deducted, okay? Hmm. So 1, 3, 4. Yes. So the other things are not things you would want to stop the medication or you want to discontinue oxytocin. Fatigue, drowsiness, early diesel we know is good. The only abnormal thing here, hyperuterine stimulation, and then um when there is late diesel. If you have a question, kindly feel free. Okay, if you don't understand anything, feel free to ask whatever you don't understand so that we all go through it together. Okay. A pregnant client is receiving magnesium sulfate for the management of preeclampsia. The nurse determines that the client is experiencing toxicity from the medication if which of the findings are noted on assessment. Select all that apply. One is a proteinuria of 3 plus, 2 respirations of 10 breath per minute, 3 presence of deep tendon reflexes, 4 urine output of 20 ml in an hour, and then serum magnesium level of 4. It is also SATA. Some are going for 2, 3, 4. Some are going for 2, 4. Others are going for 2, 3, 4, 5, and all that. Okay.
Flamingo.
Yes, madam.
I want to define my choices.
Let's go.
So I chose 2, 4, 5. I'm not too sure about 5 though, but let's see. So you made mention that respiratory rate of less than 12 is a sign of toxicity. So if the respiration is less than 10 breaths per minute, then it means that there is a toxicity for it. And then a urine output should be at least 25 to 30 mils per. So if I'm getting 20 mils in an, it means the renal function is being impaired. And then serum magnesium level of the normal um was that we made mention was 1.7 to 2.6
That
milligram per
is
deciliter.
that is the
Serum
normal serum
magnesium
magnesium
level.
level. But
Yes.
I made mention of something else. Do you remember what I
Therapeutic.
said?
Yeah, you said therapeutic.
Uh-huh.
I didn't
So
get that
there's
number.
so there's
I
difference
heard the
between
therapeutic.
so there's difference
Okay.
between there's difference between the serum magnesium level and then the therapeutic level.
Therapeutic levels. Okay.
Uh-huh.
Okay. So I'll go for 2 and 4. The reason why I didn't take 1, proteinuria of 3 plus it means that the magnesium is not working. So it's still preeclampsia sign. And then presence of deep tendon reflex. It means that the magnesium is working because if there is toxicity, there should be a reduced deep tendon reflex or an
Reflex.
absent deep tendon reflexes. That's why I
Okay.
didn't think that. Yeah. So
Okay.
that's my offending defense.
All right, thank you. So this is it. Those who are adding the 5. Okay. That's why I said that when the person is on magnesium, definitely the serum level will go up above the normal serum level because we are giving magnesium. So we now look at the therapeutic range. The therapeutic range is 4 to 7.5. Not the moment the person goes on the medication, we are not looking at 1.7 to 2.6 or 2.5. We are not looking at that again. We are now looking at the therapeutic range, which is 4 to 7.5. I hope you guys get me. So that's why I was trying to let BB understand that now the person is on medication. So we are not looking at the serum level. We are rather looking at the therapeutic level. Okay. We are looking at the therapeutic level now. Okay. So we are looking at the therapeutic level now. Any question, any inputs, any clarification? Feel free to come up with whatever you want to ask.
Hello, boss.
Yes, madam.
Yes. Sorry, I got a bit distracted. So does it mean that the magnesium levels are not bad? I didn't get the therapeutic thing
Okay.
you said. Sorry,
Okay.
please come again. Sorry.
Okay. So when I was doing magnesium, I spoke about when I was in max of it, I said that we have normal serum magnesium level and we have the we have the therapeutic level. Okay. Where when one is taking the magnesium, we have to maintain the level. So if the person is not on magnesium, for instance, now if you go check your magnesium level, the normal should be between 1.7 to 2.5, 2.6, depending on which one you are using. That should be the reference range if you are not on magnesium sulfate. But the moment you start taking the magnesium, or the moment you start taking magnesium sulfate, or you start giving clients magnesium sulfate, we don't use the serum level. We rather look at the therapeutic range because now the individual is taking magnesium. So automatically magnesium level will go up. And so now we use what we call the therapeutic range. And so the therapeutic range for someone who is on magnesium sulfate is between 4 to 7.5. I hope you are getting me.
Oh,
So
okay. So then it means that this one is within the range because the
yes,
person is taking the max off.
because
Okay.
the person is taking the medication. I hope you get
Okay.
me.
Yes,
Uh-huh.
please. Please
That
let me
is
see the
why
question again.
this was the question.
Okay. All right. Right. Thank you.
Welcome. Any 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 question? Okay. Let's look at this. This is very simple. Metala Gonavine or whatever is prescribed for a client with. Maki will say that you don't need to know them. You don't need, all you need to know, if I spot this, if you spot this, you know that, okay, this is the medication I'm reading on, and this is what I need, okay. However you pronounce it. I mean, so Vitagonavine is prescribed for a client with postpartum hemorrhage. Before administering the medication, the nurse would contact the obstetrician who prescribed the medication if which condition is documented in the client's medical history. Hypotension, hypothyroidism, DM, and then peripheral vascular disease. This is very simple. So if you are here, this should be very simple as ABC. Okay, very simple, very simple. Okay, very simple, very simple, very simple. Hey,
Flamingo.
hey, hey, hey! Comment section, I had it.
Flamingo.
Comment section, I had it.
Hey,
Uh-huh.
do we use this medication in our setting? Because I've never seen it before.
We've never seen it, eh?
Mm-mm.
That's why it's the
It's
US.
just the cytotech and then the oxytocin infusion that they give after
It's,
delivery. Yeah.
so yeah.
I think it's the same as ergometrin. Is it ergometrin or
Yes, yeah,
Is
it's
it
the
the
yeah,
same.
same?
ergometrin? Yeah,
Oh,
we call it
okay.
ergometrin, but
Yeah,
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 that is the name,
it's
the
the
other
same.
name
Yeah,
for
it's the
it.
same as the
Hey,
government.
Yeah.
Yeah,
and
it's
this name is different. Wait.
yeah,
Yes.
it's the same. Okay, so I've
Ah,
seen people answering, but I'm very curious about the answers they are going for.
Hello, boss.
Yes.
When you were talking about this medication,
Mm.
you said, I remember you said it causes vasoconstriction and vasospasm,
Mm,
Uh-huh.
and so it's contraindicated in hyper.
yeah.
Hello. Nana, kindly
Hello.
mute for us. Yes, Ellie, go ahead. Let me mute her.
Yes, you said it causes vasoconstriction and vasospasms in the of the arteries. So
Yes.
because of that, it's contraindicated. Like you have to be monitoring the blood pressure. So because of that,
Mhm,
it's contraindicated in hypertension.
mhm.
So looking at the question, I don't see hypertension.
Mhm,
I rather see hypotension.
mhm,
And the question is asking what you should like before administering, what you should look out for.
mhm. So
So me, I'll go for number four
you go for number 4.
because like
Uh-huh.
uh, be,
Okay. Tell us why.
because because peripheral vascular disease is like part of all those cardiovascular diseases. I think
Yeah,
I would go for
you
number
go for
four.
number 4.
Yeah.
So you see how quick people were going for number 1. I was like, what is about the number 1 that people are
low.
I was
We've
like,
been
hey,
tricked.
people are going for number 1, fast. Remember, we said that medication causes vasoconstriction, not useful in people with significant cardiovascular condition, where vasoconstriction is going to pose a significant effect on that client. Okay, so it's rather peripheral vascular disease, where when there's peripheral vascular disease, blood flow to the extremities are affected. And so if you give a medication to someone with peripheral vascular disease and the medication goes ahead to cause vasoconstriction, what do we think is happening? You are going to restrict more blood flow to the extremities.
Mhm.
Okay, so I was wondering what is about the hypotension and people are going for it. Or because it is a heart-related condition. So it's
Listen,
yes, hello.
Yeah, I was also thinking the same as my sister was saying, but peripheral vascular disease, with the hypertension is cardiovascular, isn't it? So it's a
Yes.
bit, so that's, yeah. So I don't know. So the peripheral vascular disease, you can attribute it to high blood pressure,
Yes, yes,
hypertension.
yes, exactly, yes.
Really?
Yes, of course. If when you take risk factors for, I mean, what do you call peripheral artery disease, hypertension could be part. Okay. And then
Okay.
when there is not enough blood supply going to the extremities and all that, when you have atherosclerosis occluding the
Mm,
vessels leading to the peripheral artery disease. And then hypertension, like I said, is also one of the risk factors that could lead one into having peripheral artery disease. But what I want you to understand that in peripheral artery disease, it is also part of cardio conditions. I don't know whether you understand. Peripheral
cardiovascular.
artery disease is also a cardiovascular related condition. And
Okay.
then the main thing happening is that there is what you call an occlusion in the vessel
Okay.
that supply blood to the lower extremities. Okay.
Yeah.
So there
Yeah.
is no much blood supply to the extremities,
Okay.
especially the lower extremities. So if someone is having what you call peripheral vascular disease, and you go ahead to give a medication that will further cause vasoconstriction, then you further impede blood flow to the
Yeah.
extremity. I
Yeah.
hope you get me. Uh-huh.
Yeah. 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 Yeah.
So
I
that
get
is
it. Thank you.
okay. You're welcome. So let me get our question. Let's read the question well. Oh. The question was very easy. Why you see how people are going for hypotension from the beginning. And
Oh,
then
dear.
when you go sit, we usually say when you go to Kenya or India or wherever you take, after you select next, you can't come back again. So don't rush. Take your time, read the question, analyze, and then go ahead. Okay. Some questions are very easy. When you see them, you'll be in a rush. But when you come out, then you start thinking, this question, was it the correct thing I selected? Okay, that's just by the way. All right, so let's look at this.
All right. Uh, Mister, please, I wanted to ask with the exams,
Hmm.
is it time bound, or is just
Yes,
when you?
yes. So it's time bound. I think one day we'll have to get time and talk largely about the exam. Okay,
Yeah.
we have to get time to talk about it. But it's time bound. But the questions are not time bound. But the entire exam is what is time bound. You have to finish the whole exam in 5 hours, which is it 150 minutes.
And how many questions,
So
please?
you can get between 85 to 150 questions.
Oh, wow. Okay.
Uh-huh.
All right.
So ideally you are not supposed to spend more than two minutes on a question. If you want to really if you want to really time yourself very well in terms of your
Uh-huh.
time management regarding question answering, you shouldn't spend
Yeah.
more than 2 minutes. Okay. At
o-
least every question you should use about 2 minutes on a question, 2 minutes on a question.
Okay.
Okay. Uh, that is it.
Yeah. Thank you.
Uh, let's do probably last one or some few ones, and then we'll see if we can make progress. The nurse is monitoring a client in preterm labor who is receiving intravenous magnesium sulfate. The nurse monitor for which adverse effects of this medication. Select all that apply. One, flashing, hypotension, increased urine output, depressed respirations, extreme muscle weakness, and then 6, hyperactive deep tendon reflexes. All right.
Let me try this one too. Yeah, get it right. Okay, so Samingo,
Yes, madam.
I chose 4, 5.
4, 5.
Yes.
Want to play
With my
safe game.
rationale, my rationale being so adverse effects of magnesium sulfate is just like toxicity of magnesium sulfate.
Mm,
So if there is a depressed respiration less than 12, um, it's an adverse effect. That's how it was
mm,
called. And
mm,
extreme muscle weakness is because we said magnesium works on smooth muscles.
mm,
Yeah. So if there is extreme muscle weakness, it means that the person has become like there is an absence or a reduced tendon reflex. That's why I
mm,
chose that one. That's why I chose the 2 and 4. I
okay.
didn't choose hyperactive deep tendon reflex. That one would be 4. It means that there is still um, that's not an adverse effect. It's missing that
Okay.
the medication is not working.
Mm,
And then the increased urine output is supposed to be decreased, not increased. So I didn't take that one too. And then the hypertension, when we give them Maxol, it lowers the BP. So it's supposed to have a hypertension, not hypertension. It means it's not working. It's the flashing that I'm not too sure. No, no, no. Flashing is a side effect. Because I know Maxol, when they give it, the patient will be complaining of feeling of like, the flashing feeling. So
okay.
I think it's a side effect and not an adverse effect. That's why I didn't take that.
Okay.
Yeah. Thank you.
Okay, thank you. Um, okay. She's giving us her rationale, everything. Let's see if it's fine. So the flashing is not expected. It's something that if someone reports, you have to inform the healthcare provider. It indicates that there's toxicity. I made mention of it when I was doing it. Things you need to report on. Flashing is part. Okay. So the flashing indicates adverse effects and will require you to inform the healthcare provider or to intervene appropriately. So the nurse will monitor for which adverse effects. So the flashing, when it happens, it is adverse effects. You did well. Well, I've said that if you are not sure, that was quite okay. If you are not sure, don't choose it. Choose what you are confident and you are sure of.
Yeah, no, say, Amingo, the
Mhm.
education we give in Ghana and the edu. You see that midwife say, oh, when we give you this medication, I bet to say, oh, I'm sure. Anna. And the patient also complain that they feel like a burning sensation.
Burning
Mm.
sensation.
Uh-huh.
Uh-huh.
So I was thinking it's an expected find. It means when the patient start to complain that, then it means we need to let the doctors know. But we don't do
Yes,
anything about it.
you need to, yes. So that should be, in
Mm.
fact, when you are giving medication and flashing occurs, flashing will mostly proper flashing will cause some form of redness in the face, the neck, and the chest area. Okay. The itching and what is it? Let's say if you are giving it and they are feeling that kind of that probably irritation, but for proper um flashing, it has to cause some form of redness on the face and all that, the chest area. Mostly that is what it presents with. Okay. Um, so what I want you to understand is that flashing
Hello, sir.
is expected is adverse effect that you need to report on. Yes, someone wanted to come in.
Yes, sir.
Yes, yes. Yeah, kindly go ahead.
Hello, sir.
Yes, yes, senior, kindly go
Please,
ahead.
sir, why is it that hypertension is not part? Because in the note, it is
Mhm.
stated that hypotension will occur and later hypertension.
So the first thing is the hypo. Okay.
Okay, sir.
It's a rebound effect that causes the hypertension. But if the person is actually going to experience the toxicity, it is hypotension you expect.
Okay, sir.
Hypertension will not start first. What will start first is what you call the hypotension. So the main adverse effect is the hypotension. Then there's a likely what you call rebound hypertension that will happen later.
Okay,
So
sir.
it is hypotension and later expected rebound hypertension happening. Okay.
Okay.
Okay, so far, yes, you can read about it. You're flashing, right? Okay. So far is not so much convinced about the um the flashing where it says that it has to be an indication of adverse effects. So you can read much about it as well. Okay. All right. Um, let's look at this. A client at 38 weeks gestation is in latent labor with ruptured membranes and receiving an oxytocin infusion for labor augmentation. The client is requesting IV pain medication. When administering an IV narcotic during labor, which nursing action is appropriate? Let's go on. 1. Discontinue the oxytocin infusion prior to giving the medication. 2. Give the medication slowly during the peak of the next contraction. 3. Hold until contractions are occurring at least every 4 minutes for an hour. 4. Withdraw 5 ml of lactate ringers from the IV tubing to dilute the medication. Okay. Hmm. Okay. Hey, why are people not answering this question? Is it difficult? People not responding to the question. Is the question difficult? Is it tricky? Okay. I was surprised people were still thinking. You go for 2. What did I say about your opioid or narcotic administration? I said you give it when contraction had well picked. So some people are going for 3. Why 3? 3 says that when contractions are occurring every 4 minutes. During active phase of labor, contractions should be occurring at least more frequent, right? And so you have an option which says that give the medication slowly during the peak of the next contraction. Yes, we said that we give the medication when contractions had well peaked. So that is what I was expecting you guys to do, right? I didn't know why people were thinking too much into it, into the questions. At least,
Boss,
yes, hello.
you said the question is kind of tricky
Mm-hmm.
because you said that when we're doing the narcotics, where is it in my
Mm-hmm.
notes, guys?
Mm-hmm.
You said we should give it during the active phase of labor, right?
Yes, yes,
Which is like 4 to 7 cm, right?
yes.
And now the question, but please let me look at the question again.
This is the question.
And you said the answer is give the medication slowly during the peak
Peak
of the
off.
next contraction.
Yes.
Hmm.
Which one were you thinking? So that we look at it.
No, I wasn't thinking of any. I didn't get any answer.
Should have got so what people were I saw that people were torn between the 2 and 3. Okay. Now the best is the 2. The 2 says I give it slowly. Remember, I told you that you give it when contraction had well picked. I also made mention of that, if you remember.
Yes, you said
And
well picked.
yes,
You
during
made
active
mention of
because
something like that.
yes,
Okay,
because
so it means that is during the active phase. That's when
yes,
contractions.
when contraction mostly peak at that end, okay, and you can
Um,
yes, you can like I said, that is the best time to give it. As for transition, you say no go because for transition, the client will likely go into labor or
yeah.
deliver in a very short while when you give it in transition, and it's not best. And
Mm-hmm,
when you give it at what they call latent, it's not also good, but then labor had not
mm-hmm,
well established. Or sorry,
mm-hmm,
yes, contraction are not well get established. So the best time to give it is when you have contraction being well established, and then at the peak of contraction, that's when we give it. Now, I understand someone will say that okay, the second one is a hold until contractions are occurring at least every what do you call 4
1
minutes,
minute.
which is not good because we said that during active phase, contraction should be occurring at least every 2 to 5 minutes. So if
Mm,
your yardstick is 4 minutes, this is wrong.
hmm, hmm, hmm. Okay. Okay. Thank you.
Okay, so that is that for today. I wanted to look at the other aspect of pharmacology, the other part I was talking about, but our
Hello, my
time is
lady.
up for today. And like I said, we don't want to take much of your time because other people would also want to do other stuffs after here. And so tomorrow we meet again and then we take the other areas. But before we drop off the class,
You remember putting them in
if you
the
have any
on
question, if you have
the
any inputs, any
She
clarification you
said,
want to
so you
make,
know,
can
when
make it
you
Samingo,
before
nobody this much
we
family,
um,
you know about it, and
please, can I
relationship,
see the
you know
rationale
about
for
it.
the narcotic medication?
you want to see the rationale.
Yes.
Okay, let me see if I can bring it back. Okay, this is it.
I'm a screenshot. Okay, thank you.
Okay. I think we can end here if there's no other question.